Hello and good evening to all of you. So this is a new module, the core surgical skills and post-operative care module. So post-op care, we will be discussing the complications. So you can get stations on bladder injury, ureteric injury as well. Then simulated patient tasks. Then there are a lot of structure discussion tasks and bowel injury, broad ligament hematoma, pulmonary embolism, so many cases, and acute kidney injury, there was structure discussion task. For surgical skills, you have to be you should know about all types of hysterectomies, vaginal hysterectomy, total abdominal hysterectomy, cystocele repair, surgical management of miscarriage, third and fourth degree perineal tear repair. Very important surgical stations. Instruments you have to go and see wherever you're working in the hospital. Those who are not working, please go and see all the instruments, hold them in your hands, and then like that is very important. Like in the teaching, if there is ventuse and forceps, like forceps station is also a very famous one. So you have to apply the forceps, apply the ventuse, only then you will do it confidently in the exam. All right, so let's begin. Okay, so few of you have chosen your station. That's okay, no problem. Okay, Shweta, you can start with your station, no problem. Come, please.
Yes.
Okay. One moment. Yes, and take you 2 minutes, but read everything carefully, okay? Even if you know the station, read everything carefully. You
Yes.
have 2 slides. Okay.
Okay. And I want to do this according to new consent form
Oh, all right. Okay, fine.
because I downloaded that one and then yeah.
All right.
In consent taking form that will come. Otherwise, history taking would be similar for.
Yes, yes, but the consent
Yes.
form, I have not changed. It is that same. I mean, okay,
Yeah,
but
but
this
I
one you have
downloaded
to,
that one.
yes, yes. That is why I have not, like, I have just written in the bullet points. So you will discuss
Okay.
all this as per
Mhm.
the new consent form. Exactly. Okay, fine.
Okay. Yeah.
Okay, start reading. Take you 2 minutes.
Yes, I'll see.
Hmm.
Yeah. Can I start?
Yes, start, please.
Hello, I'm Dr. Sweta, one of the doctor in preoperative clinic today. Am I talking to Mrs. Lena Brown, 35 years old?
Yes,
How can I call you?
call me Lena.
Lena, I understand that you are here because you are here to sign the consent form for diagnostic laparoscopy. Am I right?
Yes.
Lena, before proceeding further, I want to ask few questions to know more about you, and after that, I'll come to the consent form. And is that okay for you?
Okay, yes.
Mm-hmm. So, may I know why you are going for diagnostic laparoscopy? For which condition, in your own word?
Yes, actually, I am having severe pain during my
Mm-hmm.
periods. And also, me and my partner, like, we are trying for another baby. So, my clinician, she told me that most likely I have this condition, something she told me endometriosis. And so they have to do this keyhole surgery.
Yes, yes, Lina. I can see that you have gone through a lot and you had pain, and this laparoscopy has been decided for you. So, Lina, may I know about the pain? Since when you have?
Yes, it is long-standing pain for more than
Mhm.
8 months now.
Have you taken any treatment for that?
Yes, I was taking some painkiller, then I also took some hormonal tablets, but there
Mhm.
was no relief.
Okay. So, has all the treatment have been discussed with you
Mm,
regarding this endometriosis?
yes,
Before-
yes.
Okay. So, may I know about your periods? When was the last one?
Yes, that was about 10 days ago.
Mm-hmm. And what about is its flow?
Yes, the flow is okay.
Any pain during period?
Mm, yes, yes. I told you I have severe pain during the periods.
Okay. So, uh, some of my questions are personal and intrusive, Lina, but I need them. Are you with someone now?
Yes, I have my partner, David.
Mm-hmm. Are you sexually active?
Yes.
Okay. Do you have any pain during sex or any bleeding after that?
Um, yes, sex is very painful, but
Mm-hmm.
there is no bleeding, no.
Okay. So, any medical illness for which you have been visiting your GP regularly?
Mm, no,
Any surgery done in the past?
no.
And I can see that you have one child and delivered by cesarean section. Was there any complication at that time? And how did you recover after that?
Well, no complications, and cesarean was done because there was baby's trace was not okay, but recovery was fine.
Okay. So, can I review your case note regarding that?
Yes, okay.
Okay. Are you allergic to anything?
No.
Are you taking any medicine right now? You told me that you have taken hormonal treatment and pain relief. So right now, are you taking any hormone?
Mm, no.
Okay. So which contraception did you use earlier?
Yes, I was taking the birth control pill.
Okay. So do you smoke?
I do, but now, like, I'm trying to reduce on my own, and I'm taking 1 to 2 cigarettes now.
Okay, good to know that. And so I can see there that your height weight ratio is high. It is 35. Have you ever thought of reducing weight?
Okay, I'll think about that.
Okay, if you want, I can connect you to the exercise specialist and dietitian as well. Okay.
Hmm.
So, may I know your blood group and any reservation for blood transfusion if needed further?
No, no, no.
Okay, and how is the support at home?
Yeah, so my partner is supportive.
Okay, any family and personal history of clots?
No.
I can see that you have pain since long. So, is it affecting your mood? Do you feel low down?
Yes, at times, yes.
Mhm. Okay. So, Lina, now coming to the consent form, as you are here to fill the consent form, and I can see that your observations are normal, but I want to examine you in presence of chaperone, your tummy and down below. If any swab is there, I will take that for test. Would that be fine?
Okay, yes.
Okay. So, Lina, now coming to the consent form. Next slide, please.
Yes.
Now, in the consent form, what we do first, we have. Can you tell me the process, the operation which you are going for?
Well, yes, I know it is a keyhole surgery.
Mm-hmm. And it is for what? Which condition you have?
Yeah, endometriosis, right.
Yes, yes, you are right. So, Lina, let me tell you that uh, I am taking the consent, but it is might not be possible that I would be there in the operation theater. Okay, but I am well trained in taking the consent. So, am I clear so far?
Yes, okay.
Okay, and after the consent taking, I'll give you the information, written information about that, and I'll provide you the contact number of our hospital. Okay, so if you have any problem, you can, if you want to ask anything, you can come later on also, contact later on also. Okay.
Right. Yes.
Now coming to the consent form, this is the consent form. And first of all, we have to write the patient identification detail. Okay, your name, NHS number, date of birth would be there, and then after that the name of proposed procedure or course of treatment. As you told me that it is the keyhole surgery, and that is the diagnostic laparoscopy. So let me explain that to you. So keyhole surgery is here a cut is given in the tummy through the tummy button to look inside the tummy, and we look around, and if any pathology is found, then that is sometimes it can be treated as well, but before that your consent would be taken. Okay. But in your case, as I can see that you have previous surgery, and you have a high height weight ratio, so this route might not be possible in your case, so we have to go for another route. We call it Palmer site, or we call it open Hassan technique. So in that case, the alternative site is chosen, like in the upper part of tummy, and the midpoint of below the rib cage on left side, and 3 centimeter down from the rib cage in the middle line. Are you with me?
Yes. Okay.
But we have to just rule out something, that in previous surgery should not be there, and organ called splenomegaly, spleen should not be enlarged. Okay. And in open Hassan, what we do, just we cut through the whole layer of skin, and we directly go inside the tummy to see that adhesion is not there, any scar is not there, so that less chance of injury. Okay.
Right.
And after that, the treatment we take, extra procedure might be needed, like if we some unusual pathology is found, then we can take, like endometriotic spot is there, then that can be burnt sometime. Some biopsy can be taken from that time. Okay, so just if you want to go for that, just you have to tick over there. Okay.
Yes.
So and the benefit is that we can get the tissue from there, and we can treat the mild procedure as well. Okay. And then there are some serious risk and frequent risks. Serious risk is that there can be injury to organ, like bladder injury, bowel injury, and then blood vessel can be injured, bleeding can happen. And I'm sorry to say that in this case, there are, because height weight ratio is high, adhesions are could be there, so these all risks could be more. Okay.
Okay. Mm-hmm.
And then frequent risks are also there, like sometimes it is there that infection can happen, and there could be the chances of hernia at the stitch site, at the where we go inside, at that that can happen. And also there are sometimes chances of bleeding can happen over there. Okay.
Yes.
Pain, discomfort, all can happen. These are the frequent risks. It means frequent means it happens more frequently than other. So as I told you, that extra procedure, like if any injury happened, like sometimes if organ like bladder and bowel and water pipe are injured, then repair of that become necessary. And sometimes if bleeding is heavy, then in that case we need to open the tummy as well.
Right.
Okay. So you have to sign this. I am informing you all these things.
Yes.
So this procedure will involve, the anesthetist will consult you regarding the anesthesia that can be done after anesthetist, the sleep doctor will discuss you about the thing in detail. Okay.
Right. Yeah.
And it can be done under, but this diagnostic laparoscopy is done under putting you to sleep. Okay. So then if you, then I'll sign here, and my name and my designation and position would be here, and I'll give you contact number. And if you happy to go for this procedure, you sign here. And then on the day of surgery, when you come, then you have to sign during that day also. okay, before
Right.
the surgery.
Yes.
And during the meantime, if you want, you can withdraw your consent anytime. And I am giving you the yeah, information leaflet and contact number as well. Okay?
Right. Okay. Time is up. All right.
Yes, that's right.
Okay. Fine. Thank you. Okay. So in the new and old one, there is not much difference. There is some difference in the
Yeah, I
numbers.
think,
actually.
yeah, number
Yes. Yes.
common and long term, early. Here
Yeah.
it is serious and frequent. And
Yes.
there are, yeah, early and late,
Yes.
short term
Early
and
or
long term
short term.
complications.
Yes. 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 So,
And
yes.
and one thing I found it different, that patient in older one, patient has to sign on the day of surgery also. But here anesthetist and the healthcare professional both have to sign on the day of surgery, not patient. Only confirmation of consent would be done that
Yes,
day.
yes. They have mentioned to be filled out by the anesthetist on day of surgery.
And yes,
Exactly. And
yes,
to be filled by your responsible healthcare profession
yeah,
on day of surgery.
whoever would be.
Yes.
Yes, and
Yes. So
only that, yeah, confirmation of
anesthetist and
consent or
clinician.
yes.
Yes, the person who is going to do the surgery. So whatever the form will always be there. It is not that they will not give you the form. The format will be there.
Okay.
Okay, so signed means, okay, here you will are signing and okay, and date, name, print, your position, contact details. And if it is the new one, then it will be mentioned, sign of the anesthetist and sign of the clinician on the day of surgery. So the format is always given. It can be like serious risk and the short-term risk. So just you have to go through that.
Yes.
So diagnostic laparoscopy, this is from the new GIRFT site, GIRFT
Yes.
site. Yeah. So that is your getting it right first time. It is like that.
Yes.
So more or less it is same. There is some
Yes.
difference.
And we
That is,
don't know which will come.
yes, you don't know which one will come.
Yes.
So most likely the new one will come, but whatever is mentioned, the format will be given. So just
Yeah, because they have removed from their site, consent site.
yes, yes, there is no more RCOG consent
Yes.
available. They are directing you to the this site, the GIRFT site, GIRFT or whatever they say. So well done overall. And what else? Yes, biopsies and all you told that we will also be taking the biopsies from the
Yes.
periodic deposits.
Yes.
Yes. So that is that is mentioned here in the extra procedure also, in the new consent. In the extra procedure, some biopsies and like the samples will be taken. Okay. Otherwise, the complications are all nearly same, nearly same. Okay. So history taking will be similar. I mean, there's no change in the history taking. All right, history taking part was fine. Good. Okay. Hello, I'm Dr. Ashweta, one of the doctors in the preoperative clinic today. May I confirm your name and age, please? How may I address you? Thank you, Lena. And I understand you're going to have an operation that is keyhole surgery. You can ask like this, am I right? And I am here to discuss the procedure with you in details and also to give you more information about it. And is there any other concerns or expectations from today's meeting? So I'll try to address all your concerns. Before that, is it okay if I ask a few questions to know more about your condition? Then I will explain to you the operation in detail and what to expect after the operation. I shall also be giving the patient information leaflet about the same. And by the end of our discussion, you may sign the consent if you agree to the procedure. Will that be fine? Then your information gathering. So can you tell me why are you going to have this operation in your own words? All right. So she will tell you about her condition. Be a little empathetic. Okay, I'm really sorry to hear about that. I can see that you're really going through a tough time. You asked all these questions. Very nice. Have you taken any treatment for that? Anything which improves or worsens the pain? How about your water work and the bowel opening? And how is it affecting your quality of life? It must be very difficult for you. How are you coping? Gynae history is important. When was the last periods? Can you tell me more about your periods? Are you updated with the cervical screening? Are you on any birth control method? I would like to ask you some personal questions. Are you sexually active and any problem or pain during sex? And I can see that you have one child delivered by cesarean section. So may I know why cesarean was done and how was your recovery? I would, and yes, any Are you following GP for any medical condition like diabetes, high blood pressure? Are you on any medication, any allergy, and any surgery other than the cesarean section? Any family history of clots or any personal history of clots? May I know, do you smoke cigarettes or drink alcohol? So if she's a smoking has no beneficial effect and it can interfere with the healing after the surgery and your recovery. So is it okay if we put you in touch with our NHS Stop Smoking services? Alcohol occasionally, okay, no recreational drugs. And may I know what you do for a living? Whom are you living with? Is your partner supportive? Have you been feeling low or down lately? If yes, offer her the counselors, confirm the blood group. Any reservations for blood transfusion? And I can see your weight height ratio is 35. Are you aware of that? Have you tried to lose weight? But this BMI is important because we have to address the issue that the risk of complications in patients whose BMI is high. Thanks for these informations. Would you like to add anything important? So I would like to examine you with your permission and in the presence of chaperone to assess your general health. I will be asking my nurse to check your blood pressure, pulse, BMI if not mentioned. Then also we have to offer you some investigations, the blood test to check your iron level and the urine test to rule out pregnancy. Now, let me explain to you the consent form. In the exam, show the consent form to her. So coming to the procedure which you're going to have, it is the keyhole surgery to find out the cause of the pain. And I will be writing here the name of the procedure, that is diagnostic laparoscopy. So, and I will explain to you procedure in detail as well. And you're also going to have an aesthetic review 1 day prior to the procedure, and the pain doctor will also talk to you, and all the lab reports will be checked and reviewed. And the procedure will be done under safety checklist. And this will be done after putting you to sleep. Now, regarding the procedure, may I know, do you have idea about the procedure, how it is done? Okay, this is a keyhole surgery in which small cuts will be made in your tummy button and 2 to 3 small cuts will be made on either side of your tummy. Then gas will be insufflated and telescope and camera will be inserted and some other small instruments will be inserted very carefully to have a look inside your tummy. Now, this will help us to find out the cause of your pain. We will also be looking at your womb, the tubes and the ovaries, and if we find any scar, then it will be treated at the same time. And for that, we have to take a separate consent because this one is only diagnostic. So for the treatment, we have to take a separate consent. Also, some samples will be taken and sent to the lab for testing. Am I clear so far? Any questions? Now, since you had a previous cesarean section, so we may encounter some scars. At that time, it will be a bit difficult to gain entry inside your tummy. So in that situation, we will make a small cut 3 centimeters below your left rib cage in the center, that is the palmar point. Now, regarding the pros and cons, so it is a safe procedure in expert hands, but there is some risk. There will be risk of surgery and anesthesia. The major risk can happen in 2 in 1,000 procedures like damage to bowel, bladder, water pipe, and blood vessels. There can be failure to gain entry in the tummy and to complete the intended procedure. There is a risk of hernia at the site of entry. One major risk is that there is risk of death and it can rarely occur. There is risk of clots in the legs and lungs. That is also rare, and these risks are more in obese patients. There are some frequent risks like mild and self-limiting pain, infection, shoulder tip pain, bruising, and bone gaping. If major complications will happen, then we have to involve the expert surgeon to repair. So the extra procedure done will be like if there is any bladder injury, then we have to involve the urosurgeon for the bladder repair. If there is bowel injury, then we have to involve the bowel surgeon for the repair. So this will be your communication with colleagues, involving the urosurgeon, bowel surgeon, anesthetist to discuss about the anesthesia. This is all communication with colleagues. What are the other extra procedures? So we discussed about the repair of bowel, bladder. Open surgery can also be needed. And open surgery or repair of bowel, bladder, or blood vessel, or even blood transfusion if there is excessive bleeding. So I'm going to mention all these here. What are the benefits? So the cause of pain can be found and it can be treated at the same time. Then after the procedure, you can just add a few lines that you will be kept under observation. There will be drip in your arm to give you fluids and tube in your water passage to help you pass urine and assess your urine output. And we will be discharging you once you are stable, and you can be discharged home either same day in the evening or next day. Depending upon your condition, we will offer you the painkiller to reduce the pain. Follow-up appointment will be given to discuss the lab results of samples taken during the procedure. Any questions? So I will be signing here. You will show, and it means that I've explained everything to you. I will give you the consent form. You can go through it. Once you're ready for the procedure, you can also sign here, and I will also document our discussion. We will give you the patient information leaflet about the procedure. So on the day of the procedure, again, we have to reconfirm that you have signed the consent and you are still ready for the procedure. And as well as, like, we can add the points which Shweta has said, that the anesthetist and the clinician who is responsible for you, they are also going to sign that, sign the form. Okay, I will share that new one in the group, okay, the PDF. Although all the consents are in that consent group, the new ones. So you can have it
Yes,
there.
yes, these are there. Yeah, we saw
All
that.
of them are there. Yeah.
Yes.
So now give the contact numbers for clinical access, and if you have any query, contact us, and we would be happy to answer you back. Well done. Good.
But I missed many points. Actually, I thought that consent form would be there, then I can look for that and
Okay, this is the old one only. This is the old one. This is the filled one, but I will change and I will put here the new one. Okay, I will do that. Right. Consent form will be there in the exam. So
And
what?
otherwise, we can look at the consent form there also, na, in the exam and
Yes.
speak about all the risks.
Yes, yes, yes. Like here, I have just typed it. So it will be the consent form there. And everything will be, you have to fill in the blanks. Patient's name, I will be writing your full name here, NHS number, date of birth, and what is the name of the proposed procedure, course of treatment. So I'll be writing that here, the diagnostic laparoscopy, what it means, then you have to explain the procedure. And intended benefits, like it will help to reduce the pain. It may also help to find out the cause of your subfertility. Then see what are the serious risks, frequent risks. Go one by one. Yes, this will be there. And in between, you have to check the patient's understanding. Am I clear so far? Do you have any question? Yes. It can come in the teaching or it can come in the surgical module. All right. Next, I think.
Dr. Can I do now? I am Bushra.
You're Bushra?
Yes.
And after that, Anita can do, no problem. Take it 2 minutes.
Yes, doctor, I can start.
Okay, start please.
Hello, I am Bushra, one of the exam candidate, and I read this SNAYU and I am ready for this structured discussion.
Okay, so what are the possible causes of this patient's symptoms?
This case is of a post hysterectomy vaginal incontinence, and she is 60 years old woman who had undergone vaginal hysterectomy 4 weeks back, and now she came with watery vaginal discharge. So my differential diagnosis is might be she has the vaginal fistula, or because she has a leaking after the operation, and might be she has a urinary tract infection, and maybe she has a stress urinary incontinence, and maybe there is a pelvic collection and vault hematoma, and maybe there is the peritoneal fluid leakage. So, for my further management, I want to take the detailed history, examination, and investigation. So, for the second question, I would like to take the detailed history from the patient regarding her presenting complaint, that is incontinence. So, I would like to ask the patient, means since how long she has this problem? It started immediately after the operation or after some times, and it is continuous or intermittent with the coughing and sneezing to rule out the stress urinary incontinence, and there is a smell of the urine and any other unpleasant smell to differentiate between the urinary incontinence, and maybe there is the pelvic collection and pelvic abscess. And also I would like to ask the patient about what is the amount and what is the color, maybe clear color or yellowish and purulent and bloody, to differentiate about the wall hematoma and pelvic abscess. And I would also like to ask the patient about the fever, any abdominal pain, and any swelling in the abdomen to rule out the pelvic abscess and any pelvic collection. And I would also like to ask the patient about her medical history to know maybe she has a diabetes because it increases the risk of infection. And also I would like to ask the patient about her social history about smoking, and also ask about the patient any previous surgeries, because might be she need reoperation, so risk of the adherence are there. And I would also like about the patient, what is the reason for the operation, mean vaginal hysterectomy, what was the reason it was done, for the benign causes, or what was the diagnosis, any complication occurred, and who was the recovery. And with the permission of the patient, I want to review the her operative notes to see any complication, any ureteric injuries during the operation, and how it was repaired. After that, I would like to examine the patient with her permission in the presence of chaperone about her general condition, like her vitals plus pulse, blood pressure, temperature, and oxygen saturation. And also I will examine her per abdominally to see any palpable mass or maybe palpable abdomen to rule out overflow incontinence. And after that, I will do the local examination to see if she has a pad to see color of the discharge. And gently I will do the per speculum examination to see the leakage is coming from where, and also to see the how the vault is repairing, healing. And after that, I will do her vaginal examination to see maybe there is any tenderness and any pelvic collection and any mass. After the examine, and also during the examination, I will take the high vaginal swab to send for the culture and sensitivity. For the after the examination, I will do some investigation for the full blood count to see her hemoglobin, and WBC count for rule out any infection. And I will do her renal function test and liver function test to see her general condition, and urine analysis to rule out any infection. And hydrogenal swab also for send for culture and sensitivity for infection. And for her ultrasound to see any pelvic collection, abdominal pelvic ultrasound to see any pelvic collection. And for diagnosis of the fistula, if there is a suspicion of fistula, then I can perform the 3 swab test with the methylene blue. And for specific test, I will do her IV pyelography to if there is a suspicion of the uretero-vaginal fistula, and for the cystoscopy to direct visualization of the fistula site, and retrograde cystogram, all the diagnosis of if there is any suspicion of the fistula.
All right. So fistula has been diagnosed. It is VVF. So discuss her management.
If the fistula is diagnosed, I will explain the patient about the diagnosis, and the further and I will involve the multidisciplinary team involving the urogynecologist consultant and the urologist, specialized nurses, and the counselor. And the further management depends upon the size of the fistula. If the size is less than 5 mm, then we will proceed for the conservative management. For that, I will give the patient antibiotic and analgesia, and also for any skin excoriation, give the emollient and the barrier creams, and put the catheter for at least 12 weeks. And after the 12 weeks, we will call the patient for follow-up. And before removal of the follow-up, we will do the retrograde cystogram. If the size of the fistula is more than 5 mm, then we go for surgery. And surgery should be done by the expert urologist. And then we will follow the principle of the surgery. I mean, we will circumcise the track of the fistula and mobilize it. And after that, all the rules of the bladder repair will be followed. Like repair should be done in 1 or 2 layers by using the absorbable polyglactin 20 or 2030 sutures, and sutures should be 0.5 to 1 centimeter apart, and there should be and from the angle should be 0.5 to 1 centimeter lateral to the angle. And the repair should be watertight and should be tension free. And if after the mobilization, if there is needed, maybe a graft is needed to put between the vagina and bladder. So for that, we can take the vaginal fat and maybe omentum patch to promote the healing. And after the repair, we will put the catheter for 2 weeks. And for at the time of the discharge, the urethral care the catheter care should be teach to the patient to avoid any blockage and kinking. And call the patient after 2 weeks, and before the removal of the catheter, we again do the retrograde cystograph to see the fistular tract has been healed or not. I will also do the duty of the candor and explain the patient and apologize the patient. And I will raise the incident report about this incident to avoid the further not happening like this kind of incident. And also I will inform the risk management team, and all the documentation should be done. Patient should be assessed for the VTE, and for the so if needed, can we give the enoxaparin to avoid the DVT. And also patient should be discharged on the antibiotic to avoid the infection.
Right. So you have told about, okay, fine. That was the management principles of repair of VBF. Just in brief.
The principle of the repair should be done by the expert doctor, urologist, and the fistula tract should be circumcised and dissect and mobilized. The repair should be watertight and tension free, and the absorbable suture should be used, that is polyglactin 20 and 30, and the suture should be 0.5 to 1 centimeter apart from each other, and patient should be catheterized, and must be patient advised about the correct follow-up, and urinary catheter care should be explained to the patient at the time of the discharge. And red flag sign should be explained to the patient if anytime she has abdominal pain, foul smelling discharge, bleeding, and kinking of the
Okay, time.
urinary, come into hospital immediately.
All right. Fine. Time up. Well done. So, yeah. You told about the clinical governance parts, isn't it? Points, incident, I mean, all the Ds, debriefing, duty of candor.
Yes, I explained.
Very important patient safety point in the post-op complication cases. Never forget that in the exam. It has got asterisks. So, very important patient safety. Fine.
Yes, I explained.
Yes, even this is very important recall. And well done. So, just a minute, 1 minute. I'll just have some sips of water. I'm having dry throat. Give me a few seconds. All right. Hello, I'm Bushra and I'm ready for the discussion. So what are the possible causes of this patient's symptoms? So always start with the S bar. So what is the situation here? So I can see this patient is a case of post-vaginal hysterectomy incontinence. Her hysterectomy was done 4 weeks ago and now she has come with the leakage of fluid. So the causes of watery vaginal discharge could be because of the infections like UTI or wound infection, fistula like vesicovaginal fistula or urethrovaginal fistula, incontinence like overflow or stress urinary incontinence, pelvic infection or pelvic hematoma, pelvic abscess, peritoneal fluid draining through an open vaginal vault. How would you assess this patient? So assessment is always your history, examination, investigations. So for the assessment, I have to take the detailed history from the patient and offer examination with the permission and in the presence of chaperone, and then request the relevant investigations. So regarding the leakage or discharge, I would like to know when it started. Did it start immediately after operation or after some time? How is the smell? Urine-like or foul smell? How about the color? Clear yellow or blood-stained or purulent? How about the leak? Is there any continuous leaks? So that is indicative of vaginal fistula, or overflow incontinence or leak is associated with stress urinary incontinence. Whether she can void, because if vaginal fistula, there is no voiding, and whether she's having urinary symptoms like dysuria, increased frequency, urgency. And this is indicative of UTI, any history of urinary problems prior to surgery, any history of fever. So this is indicative of UTI and infection. Whether she's having any abdominal pain or swelling, this is indicative of pelvic hematoma or pelvic abscess. And I would like to know about her medical history, whether she has any medical condition like diabetes, because it can increase the risk of infection and poor wound healing. Whether she's on any medications like diuretics, whether she has any allergy, because we have to give her medications. And how about the support at home, whether she smokes cigarettes, because this is associated with poor wound healing. Whether she is sexually active and whether she resumes sexual intercourse, and if she is having dyspareunia. So it is indicative of wound infection. I would like to know the details of surgery. What was the indication? Was it because of like any history of cancer? Did she receive any radiotherapy? And I would like to go through her operation notes, whether she had any intraoperative complication like injury to the urinary tract and whether it was repaired meticulously. How was her recovery? Did she take her antibiotics? So going through the operation note is also information gathering. Now, regarding examination, it's going to be head-to-toe examination. I would like to know about her observations. If it is not given, then you have to mention everything. Blood pressure, pulse, temperature, respiratory rate, oxygen saturation to know that the patient is hemodynamically stable. Then what about her BMI? High BMI increases the risk of infection. And I would also like to know about her VTE risk assessment. Then abdominal examination to check for tenderness, if there is any palpable mass or palpable bladder. Vaginal examination. First, I will be doing the inspection of the pad for any discharge. Speculum examination is done very gently to look for the urine leak, inspect the vaginal vault and wound healing. At the same time, I will take high vaginal swab for culture and sensitivity. Then I will be doing the bimanual pelvic examination to check for tenderness, any pelvic collection, like pelvic hematoma or pelvic abscess. Then regarding the investigations, start with the simple investigations first. So we will be offering the blood test, the full blood count, white cell count. It will be increased in infection, hemoglobin to confirm or check for anemia, urea and electrolytes, kidney function test to assess the baseline renal function, urine analysis from the catheter sample for infection, random blood glucose if she is a known diabetic, and ultrasound scan. This will be the pelvic abdominal scan for pelvic collection and post-void residual urine volume. For further tests, we'd like to admit the patient. So this will be the methylene blue 3 swab test. This will help to know the site of fistula and also help to differentiate between the vesicovaginal and uretrovaginal fistula. Then CT urogram. This will also help in the diagnosis of fistula, intravenous pyelogram to assess the upper urinary tract. micturating cystourogram, retrograde pyelogram, and cystoscope. This will also help to visualize ureteric orifices. So whatever investigations you are doing, try to justify few of them, that why you will do them and how are they going to help you. Now, fistula has been diagnosed. So this is VVF. So discuss her management. Regarding the management, it's going to be the multidisciplinary team care involving my consultant, the surgeon who did surgery, urologist, specialist nurse, physiotherapist, counselors. So this is your communication with colleagues, 2 by 2, if you will name all of them. Communication with colleague is also your patient safety. I will explain the diagnosis to the woman, and either you can say all these clinical governance point here or even in the end. Then I have to perform the duty of candor, debrief the patient about her condition, apologize, and then I will fill the incident form, that is the DATIX form, notify the risk management team. Regarding the further treatment, initial treatment will include offering the barrier cream to prevent skin excoriation, incontinence pad if she is not using it, and antibiotics after ruling out any allergy to reduce the risk of infection. Definitive treatment will depend upon the review by urologist and the size of fistula. So if the size is a small, that is less than 0.5 centimeters, initially, this will only need conservative management. So we have to catheterize for 3 months. This will help in spontaneous healing. But if the size is large, more than 0.5 centimeters, catheterize for 3 months initially. Then surgical repair is done either by the abdominal route, that is by laparotomy or laparoscopy, or the vaginal routes. Educate the patient on the catheter care. Now, regarding the post-op management, so we have to offer thromboprophylaxis to reduce the risk of thrombosis, antibiotics for 1 week, catheterization for 2 weeks. Cystography prior to catheter removal is very important to confirm that fistula has healed. This is also very important patient safety. Cystography before removing the catheter. Regarding the follow-up, the patient should have regular follow-up, and it's going to be shared care between the urology and gynae department. I will also give her the written information leaflet about her condition, tell her about the warning signs and symptoms, that if she goes home and she has UTI, fever, difficulty in passing urine, any leaking, bleeding, or abdominal pain, she should report to us immediately. And for that, we have to give her the contact number. What about the principles of repair of VVF? So just in short, it has to be done by urologist. It has to be watertight seal. The sutures used are fine sutures like 2,0-polyglactine. So first we have to circumcise the fistula, then dissect the tract of the fistula, mobilize it, and then repair the bladder in 2 layers, and then close vaginal wall over the repair. So for the bladder, the suture used is 20 or 30 Vicryl. Okay. So this is the VVF structure discussion. All right. Anita, can you do the case? If you're ready. She is joined or not today. One moment. I think I got.
Ma'am, I'm joining.
Okay. I was searching your name. All right. Okay. So you're ready?
Yes, ma'am, I'm ready.
Okay. Take your 2 minutes.
Yeah, sure. Ma'am, next page can I see?
Mm-hmm.
Okay, ma'am, I'm ready.
And there's one more. Okay, this one. Right? Fine. Go through it. You still have few seconds. Okay, start
Yes.
please.
Hello, I'm Anita. I've gone through the case scenario and I'm ready for the discussion.
All right, so summarize the case and what is your most likely diagnosis?
Yeah, this patient, she is on her day 2 of post hysterectomy with done for with breathlessness and chest pain. From probably this will be a case of pulmonary embolism to me. And after seeing the investigations and yeah, assessment for her.
All right. So, yes, see the investigations and tell what do you think is
Yeah.
most likely
So
diagnosis?
seeing the
Yeah.
investigation, what I can see in the as the on the day 2, the patient's respiratory rate is increasing, and also she's on having high pulse rate, and also her saturations are falling. For following this, seeing these investigations, and also the previous chart where I can see the patient has not combined oral pills were not stopped for her, and also she has been started on enoxaparin right now. So probably this will be a case of pulmonary embolism.
Yes. Okay.
Mhm.
So, so what would you like to do in her case? What do you think went wrong? Like,
This case needs to be risk analysis and management needs to be done in her case, and duty of control needs to be followed. As I can see the risk factors, which here it is like the combined pills has not been stopped for her, as well as the heparin was not started considering her high BMI, and also another risk factors, she has also undergone a surgery.
okay, so what is the importance of risk management and root cause analysis?
This root cause analysis is generally done to find out like any incident which may have compromised patient safety. And in this case, we will involve all the will involve all the people taking care of the patient, and will be professionals, and the consequences will be hard and the consequences which has resulted to that. And also, like, it is important, it also tells us about how can we improve our care for the patient, and also we can learn from this by doing reflective practice, and improve our future practices also.
Yes, okay. So discuss in brief your immediate action and further management in this case.
My immediate action will be divided into clinical and the clinical governance part. First, as the patient is having pulmonary embolism, she'll be in HDU, where she'll be continuously monitored, regularly monitoring her pulse, BP, respiration, saturation, and also like heparin will, as it has been started, will be continued. Combined oral pills will be stopped, and hydration will be checked for her. She is completely hydrated, and also high risk will also involve the MDT for her, especially the consultant, the hematologist, and the physicians, and the pharmacist also. And in the clinical governance part, we'll do our duty of candor, explaining to the apologizing to the patient about the lapse in the care, and also the ethics incident report will be filed for her. Debriefing will be done, documentation will be done, and yeah, I forgot one.
Okay.
Hmm.
And further management like admission in HDU, and then how will you manage?
Yeah, as the patient has been admitted to the HDU, I'll first of all like to gather information gathering from the patient. After seeing if she is stable and she is ready to answer my questions, I like to know about. I'll like to go to her post-op Muse chart, where I'll see. Where I'll see her routine investigations, and also whether the heparin has been continuing and all. And I'll also like to go to her post-op case notes to see whether during the operation, all the measures, like considering her high BMI, in pneumatic compression stockings were pneumatic compression stockings were done or what, foot impulse devices were used or not, whether the adequate hydration was maintained during the OT or operation, and also whether the hematologist opinion was taken for her, and also whether the whether the WHO checklist was followed, and also the, like VT risk score assessment was done in detail for her. I'll also like to go for her drug chart, seeing whether which all medications she was on and whether COC was not stopped. And during the intraoperative period, I would like to know about I like to know about our antenatal reports, where about asking her about her symptoms currently, and also about her height weight ratio, whether she has any significant family history of clot, and about any other like any nausea, vomiting, which may have led to the dehydration during the post-op period. And also I'd like to know about previous surgicals detail, and any other high risk factors like oral SCs already on oral contraceptive pills, and in the whether and in the post-op, then I would like to know about whether the patient was adequately mobilizing, eating, drinking, and also yes, and after getting the information gathering, as the investigation has been done, I'll further like to this investigation will further be continued for her.
Mhm.
And then I will like to do the root cause analysis, root cause analysis of this patient, where I'll first of all I'll see whether the incident reporting has been done, and this case has been decided for the investigations, and this will take around 72 hours, and then a team will be formed, comprising of the clinical lead of the root cause, the physician, the consultant, also the all the care members involved in her care, like all the staffs, and they will be interviewed regarding by questions regarding what was wrong, what went wrong, and also I'll go through the case notes and the detailed history of the patient to find out any fault. After gathering the information from the staff members, I'll also like to check whether there was any fault at our level in the way, like there was any fault at the communication level, because the patient was not stopped on oral contraceptive pills and heparin was not started. So whether there was any lapse in our communication, and also whether there was it was a very busy the staff. There are shortage of staffs, and also it was a busy day, and the regular portfolio, the ratio checklist and VT risk assessment scorings were overlooked. After that, root cause analysis will be done. Root cause analysis will be done in the 7 steps, like as we have already identified the risk and decided to investigate. Now, further, we have to form a team. And after forming the team, the next step will be to look into to gather data, and another next step will be to find the contributory steps as patient. To find the contributory factors as well as patient factors, and these all factors will be put in the EC-cover root cause analysis chart, and further actions will be taken for the case. And after that, the next step in the management will be root meeting and control and meeting. So in the meeting, all the people involved in the patient care, like the physicians, our staff members, our consultant, and also the ST5, ST3, ST4, whoever was involved in the patient care, we'll all call them, and a meeting will be organized to see what happened and why it happened, and how can we prevent it in the future. And we'll be very hard on the topic, but soft on the people, and recommendations will be made to further prevent such situation arising again. And like what was rising again. Then further risk control will be done, but risk control and learning will be done.
Time up, keep it short, okay?
Okay, and in the learning process, we'll just we have learned and we have to follow the WHO checklist. We have to see the VT score, assessment has to be done properly, communication has to be proper, and then root cause analysis loop will be closed with further action, further recommendations.
Right. Okay. Overall good. Very well attempted task. It was a tough station when it came in the exam. It came long back, 5 years ago, and then it came again last time. So it was a tough station, but this is more or less like your audit. The root cause analysis, the steps are like your audit steps. So let's discuss summarization of the case and what is your diagnosis. So when you will be discussing the diagnosis, just complete it. You will summarize the case and according to the observations given and the drug chart given, so most likely diagnosis is pulmonary embolism. Like other causes could be any cardiac condition if she is having, but here most likely it is pulmonary embolism because oxygen saturation is less. And COCP, she was still taking COCP and low molecular weight heparin was not started. And also she is having breathlessness and chest pain. BMI is also high, so this is also a risk factor for venous thromboembolism. All right. Good, otherwise. So just take care of the charts in the exam. Some candidates said that like the calculation and the VT risk assessment was also done in a wrong way. So you have to comment that as well. So here, what is going to be the risk for this patient? Age, risk score will be 1. BMI, risk score is 1. Okay, so although she's not having any risk factors, I mean, just it is 2. But the main risk factor will be she was taking COCP, and ideally, when should we stop the COCP before the procedure?
4 weeks prior to that.
4 weeks back, exactly. Okay. Hello, I'm Anita and I'm ready for the discussion. So summarize the case and what is your diagnosis. So this patient has developed pulmonary embolism and she is day 2 post-op with a BMI of 34. TH was done 2 days ago. She is now complaining of chest pain and breathlessness. Low molecular weight heparin has been started now. That is on day 2 post-op and the COCP has been stopped now. And her observation chart assessment is given. That is the news chart. And the most important finding is that oxygen saturation is 86%. The respiratory rate is also high, and she's also having tachycardia. So she was having tachypnea, tachycardia, and low oxygen saturation. So I will write an incident report and inform the risk management team for root cause analysis. If you're not going to say this sentence on your own, then the examiner will ask you some question that, so now what are you going to do? So it is a very serious condition. And so I will be writing an incident report, inform the risk management team for the root cause analysis. So what is the importance of root cause analysis? Few points you have to memorize. That it is done to find out the root cause of any incident which compromises the patient's safety. It has the consequences for all involved in the patient's care, including patient herself and all healthcare professionals involved in her care. And RCA and risk management is done to identify the shortfalls and substandard care provided to the patient. It also provides the learning platform to improve quality of care given to the patient. It helps in reflective practice and to improve the further practice. Now discuss in brief your immediate action and management in this case. So it has to be immediate action and further management. So the immediate action will be, I will be assessing the general condition, shift her to HDO immediately, continue the close monitoring on the news chart, her blood pressure, pulse, temperature, respiratory rate, and oxygen saturation. Give her oxygen. Like I will be asking the nurse to give her oxygen, continue low molecular weight heparin. And the care will involve the MDT, including my consultant, HDO specialist, intensivist, respiratory physician, hematologist, anesthetist, specialist nurse, communication with colleague. Then talk about the clinical governance management. I will be debriefing the patient and the team, perform the duty of candor, complete documentation, and complete the datics, that is filling the incident report and informing risk management team and mentioning in e-portfolio. Okay, then now how will you do the root cause? Okay, further management I did not discuss, isn't it? So we have to discuss the further management also. So if we will discuss the further management, then this will be, wait. So, just a minute. Actually, further management will be like we have to discuss about the risks also in the long term, what can happen. So, in like, we have to also identify okay, here. Further management will come in this only. All right, I'll go back 1 minute. Okay. So how will you do the root cause analysis for this case? So further management will be also doing the root cause analysis. Now the steps, just now again, you have to memorize, same like we are memorizing for the audit. Risk identification, risk analysis and evaluation, risk treatment, risk control and learning from the incidents, and closing the RCA loop. So there has to be a risk management team comprising of the RCA lead, consultant, or the risk management manager, just like you have an audit team. Also ST5, the seniors, ST6, ST7, and the risk management nurse, respiratory physician in her case, because it is a case of pulmonary embolism, intensivist, hematologist. Now, all healthcare professionals and staffs involved in this patient's care will be questioned regarding the incidents and patient's care. We have to review the case notes, and statements are taken from the staffs involved and reported in a chronological manner. Risk factors and contributing factors have to be identified. So in this case, what are the risk factors? High BMI 34. Even the age is a risk factor, more than 40, and she was not given low molecular weight heparin, and COCP was not stopped. So BMI more than 30, age more than 35. So our patient was in the 40s. Now come to the information gathering. So what we have to do, how are we going to identify the risk? So this will be done by history. So what happened in the post-op and recovery period, whether the patient was mobile, well hydrated, did she receive enough IV fluids, whether she was having nausea and vomiting, adequate pain control, she was given analgesics, and whether enhanced recovery program principles were followed. I would like to go through the operation notes, whether WHO safe, like it has to be done following the WHO safety surgical list, whether surgery was prolonged and any complication happened, and then the pre-op, what happened in the pre-op, VTE risk scoring was done or not, and whether it was correctly done. Then I would like to know about the medical history of VTE, thrombophilia, family history of VTE. Then medication history, I have to review the drug chart. I can see low molecular weight heparin was not given, COCP was not stopped. Then other patient safety points, like whether she was offered compression stockings, BMI is 34, so whether intermittent pneumatic compression was used during operation or not. Hematologist review was taken or not. Then you have to identify the staff factors, whether proper review and handover of cases was done or not, and staffs were overworked. Then risk analysis and evaluation means we have to see why it happened. Then we have to talk about the risk treatment and the risk management meeting. So once all informations have been gathered and risk factors are identified, the case is presented in risk management meeting to discuss what went wrong and why and how to prevent it in future. All staffs and health care personnel involved in patient's care and stakeholders are invited. We have to be soft on people and hard on issue. Then recommendations are made and disseminated through MDT meetings, ward meetings, so that such incidents don't happen again in future. And also case-based discussions are done. So the steps are like your audit meeting, what you're doing in the audit meeting. Same steps will be here in the risk management meeting. So in this case, we have to see why heparin was not started, COCP was not stopped, and if stockings or intermittent pneumatic compression was used or not. And this could be because of improper review of case notes and improper handover. And in any high-risk case, like in this case, consultant has to be involved, hematologist review should have been taken. So what about the risk control and learning? So the learning points are how to prevent such incidents from happening again. There has to be proper review of the case, MDT care and senior input, involvement of the consultant and hematologist. There has to be proper review of drug chart, VT risk score has to be correct. And in these cases, low molecular weight heparin has to be started immediately after the surgery once the risk of bleeding is less. Then we have to close the RCA loop. Now, clinical governance managed parts, if we have already mentioned, we don't have to mention everything. Importance is about the documentation. We have to document all the events in a chronological manner, how the incidence was identified and rectified, identify the short-term and long-term complications of this incidence. So short-term complication is that patient's hospital stay will increase, recovery will be delayed, and patient will need therapeutic low molecular weight heparin for a long period of time, at least for 3 months. She will need review by hematologist to change low molecular weight heparin to warfarin. Long-term complications are risk of pulmonary embolism, COCP is contraindicated in future. She will be using HRT also cautiously. We have to communicate with her GP. She will be having follow-up in the consultant-led unit. And she will be having hematologist and medical review. And discharge summary has to include all the details of the events. There has to be 3 copies of discharge summary. One will be in the file, one given to the patient, one given to the GP. We have to tell her about the warning signs that if any time she goes home and she has shortness of breath, chest pain, leg pain, signs and symptoms of VT, she has to report us immediately. For that, we are going to give her the contact numbers and the patient information leaflet. Okay, so this is the fishbone method of the risk management. So first we have to identify the problem. So how to identify the problem? You have to investigate that what went wrong. There has to be lead investigator. That what we mentioned, the lead RCA lead. Then information gathering. So information gathering will be, we discussed pre-op, intra-op, post-op, everything. So we have to, this will be obtained by interviewing people, mapping services, reviewing the clinical notes, records, and visiting the area. So checking the operating notes, the drug chart, everything is important. After that, analyze the information. Then there will be this team, the risk management team. They will start to analyze the problems to identify the underlying problems, known as contributory factors. So here, what are the contributory factors? Patient's age, BMI, COCP was not stopped, and low molecular weight heparin was not started on time. These are the contributing factors. Then generating solutions. So for this, there has to be this risk management meeting as well. And then recommendations will be made and they will be disseminated. Okay. So you don't have to memorize each and everything. Just try to practice saying it in your own language, own words. Memorizing is very difficult. You never know what type of station you will get. Then how are you going to fill this root cause analysis investigation report form? So there is incident number first, date of incident, where it occurred, in which specialty, ops gynae, what was the exact location, ward or like post-operative ward or the emergency, DATEX classification or category, like it happened because of the treatment failure and like in the post-operative period. STEES number and STEES severity level, this is not for us. I think it will be preformed STEES number. This is this will be your risk management number, like there will be complaint number. So there is going to be the STEES number. Now, what is the full form of STEES? You don't have to memorize it. Okay, I have just mentioned it so that you will have some idea about this. That's all. NHS Strategic Executive Information System. That's it. Then there will be column to describe the incident, description of the incident. So it will be described in a chronological event. What happened from the start till the end? What was the actual impact or harm to patient as a result of this incident? So our patient, she developed pulmonary embolism and increased length of stay. What were the contributory factors? So COCP not stopped, heparin not started on time. What could be the root causes? Inadequate handover, overworked staffs, or improper VTE scoring. Lessons learned. So MDT management, proper VTE scoring, low molecular weight heparin has to be started on time. COCP has to be stopped. Recommendations, same like the lessons learned, that's going to be the recommendations. Then dissemination of recommendations. Investigating team members, the name, title, qualifications, everything has to be mentioned. Now, when are we going to fill this incident reports? So they should be completed as soon as possible after the incident or accident has occurred, while events can be clearly remembered. So usually what they say, you fill it within 24 hours. Incident report forms must be reviewed in the DATEX web by the relevant nominated manager within 24 hours, but no later than 7 days. So once the incident has been reported, the concerned person, the risk management manager, they will review this complaint within 24 hours up to 7 days after the incident. And all serious incidents should be reported to NAPSA, National Patient Safety Agency. Now, out of hours, first is normally incidents is reported to the head of risk management, but out of hours, the site manager should be contacted. Now, this site manager in turn will contact the on-call director or the senior manager. So this is just a brief idea. Like suppose the examiner asked about these questions, that when are you going to fill the incident report? So as soon as possible after the incident, while we remember the events. And when it has to be reviewed, so within 24 hours up to 7 days. Okay. Next, Dr. Shanti. Yes, you can come.
Yes, ma'am.
Fine. Okay. Take you 2 minutes.
Next slide. Yes, ma'am. Previous. Yes, ma'am. Ready, ma'am.
Start, please.
Hello, I'm Dr. Shanti, one of the doctor in the post-operative ward today. Is that you are Evelyn Becker, 45 years?
Yes, I'm Evelyn Becker.
Oh, okay. My staff nurse was very much concerned about your recovery, so I'm here to see you. Are you comfortable now to talk with me?
Well, I'm having very much difficulty in breathing. I don't know what's happening. And there is some mild chest pain as well.
So, do you want some oxygen to be given?
Yes, that would be fine.
Okay, I'll ask my staff nurse to give the oxygen. Are you comfortable to talk with me now?
Yes, okay, yeah.
So how long are you having this breathlessness?
Yes, it started actually today morning.
So, do you have chest pain too?
Yes, mild chest pain.
Is that chest pain radiating somewhere?
No.
So, do you have cough?
Little cough, yes.
Any pink color sputum came out?
No, no, no.
So, any fever?
No,
Any leg pain or leg swelling?
no.
So, how was your recovery after the surgery? Like, are you taking any orals or started moving?
Well, I'm just taking some sips of water. Movement, no, it's very difficult for me to move because of the pain in the stitches.
Oh, sorry. So, may I know why the surgery was done?
Oh, yes, it was an emergency surgery. I had a big cyst. I didn't know about it. And when I came, I was having severe pain, and I was told that cyst has ruptured, and I was taken for emergency open surgery.
Okay. So, any other what any other medical conditions for which you are following the GP?
No,
Any diabetes?
no,
Anything like a blood thinning agents was given for you?
I don't remember. No,
Okay, any allergies?
no,
So apart from this surgery, do you have any other surgery in the past?
no, no.
Okay, so what about your periods? So is it regular?
Yes.
So do you use any contraceptive pills or anything?
No.
Okay, fine. So do you have any family history of clots or personal history of clots?
No, I don't remember. Regarding the pills, I used to take it, but I stopped it 3 months ago.
Okay, fine. So what about your do you some personal history? Do you smoke?
I do smoke, yes.
Okay. How many cigarettes per day?
7 to 8 in a day.
Okay. Smoking is not good for health. I will put in touch with NHS Stop Smoking Services, okay?
Yes.
Then what about the support at home? Are you well supported?
Yes.
So what about your height weight ratio?
It is 25.
Okay, fine. So I can in the presence of chaperone, I would like to examine your general condition, like your temperature, pulse, blood pressure, as well as I will listen to your heart as well as the lungs. Is it okay for you?
Yes.
So I can see that you are alone. I'm going to discuss a lot. Do you want anyone to support you?
No, it's okay. You can carry on.
Evelyn, I'm not happy with your recovery, and so we usually during your recovery we usually mark all your pulse, blood pressure, and everything, and your level, the blood is dropping fastly, and it. Have you heard about any condition called pulmonary embolism before?
No, I don't know what it is.
So what is it in a woman who has been operated? What happens is the blood, because of immobility, the blood will stay inside the blood vessel and it will become more sticky and there is more chance of getting clots. And this clot sometimes can dislodge and get into the vessels of the lungs. I'm very sorry, Evelyn. I'm suspecting that complication called pulmonary embolism in you.
Oh my God. So this is
And
something very serious?
Yes, it is. It has. We have to act very fast. So we have to. We have one good thing is we have identified it. So we have to ask. We have to act very fast. We have to make some more blood test in you to see how your kidney is functioning, how your liver is functioning, and also how your clotting function or happening in the blood. As well as we'll take urgent ECG to see how the heart races. As well as we'll take the X-ray chest also, and I will arrange for special tests like we call it as CTPA, which is a special X-ray taken for your lungs. Okay,
Mm-hmm. Right.
so your treatment will be by a group of doctors. Like I have to call my consultant immediately, as well as my blood doctor, as well as the ICU doctor, and other specialists as well. Okay.
Yes.
And we have to shift you immediately to a specialist ward called HDU, where they will give you oxygen as well as they will start you on blood thinners called low molecular weight heparin. After checking allergy as well as after checking your height weight ratio. Okay. And
Yes. Mm-hmm.
and we will also give you fluids to hydrate you, and we will also ask you to be mobile, and then we will put some stocking in your legs as well.
Right. Yes.
This blood thinning agents will be given for about 3 to 6 months, and my nurse will teach you how to give the injection and how to dispose the needle. Okay.
Mm-hmm.
And after that, we have to check whether you have any family history of clotting problems like thrombophilia will be analyzed afterwards, and we make sure that you are not given some estrogen containing pills. Okay.
Yes.
And regarding, I will give you the patient information leaflet, and I will write back to your GP also.
Mm-hmm.
There is since you have got this clot, there is a risk of getting this again also. So you have to keep yourself
Yes.
hydrated and be mobile.
Right. Okay.
So if any time you have any chest pain, cough when you have been discharged, we will give the 24-hour contact number. You have to report immediately.
Okay. And when I will be discharged?
So that will be decided by the blood doctor as well as my consultant.
Mm-hmm.
So you'll be discharged once you are stable and your condition is good.
Right. Okay.
So do you have anything to ask me?
No, just finished on time. Just now the time is up. No.
Oh.
Okay. Right.
Thank you for your time. Yeah.
Thank you. Okay, so
Yes.
pulmonary embolism, very famous station also, this one. Okay. You told about writing the incident report?
I know, ma'am, I forgot.
Mm.
It's one of the complication I should mention. Yeah.
I was waiting to hear that, yes. So
Ma'am.
many candidates are forgetting incident report. How to not forget it? When you're explaining the condition,
Yes, ma'am.
that time it is explaining the condition and writing the incident report. You cannot forget.
The mouth, yes.
Yes. Because I have noticed. You
Yes.
are explaining and everything, management and everything, and then
Yes, ma'am.
writing the incident report. Very important, patient safety.
Yes.
All right. Rest was fine except the incident report. Okay. Hello, I am Dr. Shanti, one of the doctors in the post-operative ward today. May I confirm your name and age, please? How may I address you? Thank you, Evelyn. I have been asked by the nurse to come and see you because you're having some difficulty in breathing. Am I right? I'm so sorry to see you in this condition. I will ask my nurse to give you some oxygen. Will that be okay? May I know, do you have any allergies? Once you feel better, please let me know. I'm here to take care of you. How are you feeling now? Can I proceed? So is it okay if I ask you a few questions to know more about your condition? May need to examine you, offer some tests, and then discuss the management plan. So can you tell me, better to ask about the condition first. Can you tell me more about your condition? So you're also having chest pain, and does it go to other side? Any radiation? Do you have any cough, sputum with blood, any leg pain? And may I know since when are you feeling breathlessness? And can you tell me more about your surgery? When was it done? And how was your recovery? Are you able to eat and drink, able to walk? So she's not even walking properly, just having sips of water. So all contribute 3 factors for her pulmonary embolism. And then medical history. Are you following GP for any medical condition? Are you on any medication? And are you taking the blood thinning agents? And were you giving the painkillers? Were you on any birth control pills before? So have you stopped it? And when did you stop it? Any history of clots? Any other surgery on the tummy down below? Any family history of clots? How about your partner and support at home? Do you smoke cigarettes? So smoking has no health benefit and it can interfere with your recovery. So is it okay if we put you in touch with our NHS Stop Smoking Services? May I know your weight height ratio? Thanks for this information. Would you like to add anything important? So examination finding is given here, so you don't have to offer an examination. If it is not given, then you will offer on the examination. You can skip the vital signs. Just keep it short. So is it okay if I examine you with your permission and in the presence of chaperone, just to assess your general condition, your chest, assess your chest and heart and tummy, and from down below to check for any bleeding. Thanks for the examination. And I also have the observation findings. I have confirmed the name, date of birth, and NHS number. I have serious concerns regarding the findings. So I can see that your oxygen saturation is very less. It is only 90%. The blood level is also low. It is only 9.8 gram%. Then you have to explain the condition. So from the information which I have gathered, and from the test results, most likely you're having a condition known as pulmonary embolism in medical term. Have you heard about it? So after surgery, the clotting mechanisms get activated to prevent the bleeding. Sometimes this forms clots in the blood vessel of leg and it can get dislodged. It can travel via the bloodstream and can reach the lungs, and it can interfere with the blood supply. It can form clots in the blood vessels of the lung. This causes breathlessness, chest pain, and difficulty in breathing. Am I clear so far? It is an emergency situation and it needs to be managed as early as possible. Otherwise, it can be life-threatening. I need your cooperation so that we can manage your condition as early as possible. Also, I'm going to write the incident report right away, and we are going to look into the matter that why this has happened. We are going to take it very seriously. And I will be informing the risk management team, and they will see that what happened. And once the result is available, we are going to discuss that with you. Once again, I'm sorry and I apologize. So taking things further, we have to offer you some tests which needs to be done very urgently. This will also help to confirm your condition. So the test will be, we have to offer the X-ray chest, the ECG to check the trace of the heart, special scans of the lung to assess the clots in the lung, assess for oxygen and blood flow in the lungs, the blood test to check how your liver and kidney are working, check your clotting mechanism and the blood gas level. So all the investigations you have to explain in the simple language. In fact, you can even just talk one line about the CTPA, that is a special scan of the lung to assess clots in the lung. That is known as CTPA. And ventilation perfusion scan, assess for oxygen and blood flow in the lungs. That is known as the VQ scans. So whatever it is, you have to explain it. Any questions so far? Am I clear? So regarding the further care, it's going to be shared care under a group of specialists, including my consultant, lung physician, intensive care unit physician, blood specialist, and specialist nurse. So initially, don't use the short form, full form, intensive care unit physician. So we have to shift you to the intensive care unit for more close observations, and your observations will be monitored continuously. I will be asking my nurse to continue giving you the oxygen, and we will offer you medications to increase the blood level as well, because the hemoglobin was low. And we will offer the blood thinning injection, and it has to be started right now. This will help to dissolve the clot in the leg and prevent further clot formation. It has to be continued for a long duration of about 3 to 6 months. Generally, it's a safe injection and you can have some bruising at the site of injection. Any questions? So nurse will teach you how to take injection and dispose it. Upon discharge, you can be switched to the tablet form of blood thinning agent. and this will be decided by the blood specialist. And general measures, I always say, talk about the specific measures and then the general measures. Also keep yourself as mobile as possible. We will give you the fluids through a drip in your arm, and we have to inform the physiotherapist to help you in mobility because you're finding it difficult to move around. So moving around is very important. It will help to reduce the clots. So another communication with colleague will be physiotherapist. So doctor, when will you discharge me? Once you are stable, and your discharge plans will be decided by my consultant and the medical team looking after you. Also, when you go home, if you have any difficulty in breathing, chest pain, leg pain, inform us immediately. And for that, we will be giving you the 24/7 contact numbers. Then follow-up appointment will be with the medical team after 3 months. And here we will offer test for a condition which increases the risk of clot formation, that is the thrombophilia test. So this one we have to offer. In future, avoid using birth control pill containing the hormone estrogen. This increases the risk of clots. So now I will be informing my consultant and make arrangements for your admission in the intensive care unit. I will be asking the nurse to arrange the tests and give blood thinning agent. I will be giving the patient information leaflet and document our discussion in the case notes. Any questions? No, thank you. Now, in the post-op scenarios, you will be having angry patient at times. So if she's angry, just you have to memorize few lines. I'm sorry that our care didn't meet your expectations. I'm sorry for this condition. We as a team are here to look after you. I apologize again. So few sentences should come spontaneously from your side. Yes, this is from the Green Top guidelines. So we know any suspected pulmonary embolism. So we have to start normal flow rate heparin immediately if it is pulmonary embolism. Then we are going to do the other investigations and all. Okay. We have Maria now. Yes?
Yes, Dr. Shabana.
Okay. Can you do this one? Or you want hysterectomy? Vaginal hysterectomy, I have next slide. No problem. Do you do anyone? So after Maria, I will need one volunteer. Take you to.
Okay. Next slide.
Mhm.
Hello, I'm Maria, and I've read the scenario. I'm ready for discussion.
All right. So in 10 minutes, you have to summarize the case. and then discuss the management. So go on, please.
Well, I can see this is a post-cesarean section case. Patient is having low HP as well as she's running fever currently. And basically in background, she had a history of twin pregnancy. And it was her emergency cesarean section. And after cesarean, she started heavy bleeding. And for that, she received blood transfusion. Regarding her assessment, next slide.
Yes. Yes.
Right. Regarding her assessment, her vitals in which blood pressure was low and she was also tachycardic. I guess she had a temperature, high temperature. And also regarding her investigations, her kidney function test is deranged and potassium level is increased and lactate level is lactate is raised.
Mm-hmm. Okay. So discuss your management.
Okay. Well, I would like to ask detailed history and will perform examination and run some investigation, and then we will discuss about further management plan. I have to keep in mind differential diagnosis of this case. Well, this could be due to the sepsis, as patient is running currently fever, and also her serum lactate level is rising. And or it could be due to the bleeding as patient went in PPH, and it could be due to the because of dehydration, and also could be because of some medications, nephrotoxic medication, and it could be due to the urinary catheter blockage, also injury, urinary tract injury, like ureteric injury. So I will, as I told you, that I will take detailed history. In history, I would like to know about the, especially, during pregnancy, whether she had a regular follow-up, and also about whether she was already anemic during pregnancy, and also about her overall general condition, and might be patient had a history of the UTI. Would like to review in her antenatal case note. And also would like to know about her labor and delivery. How was the labor, detail of the labor, and also any complication during delivery apart from this PPH, and any history of repeated vaginal examination, and also about whether cesarean was done on time or not, and during labor, she received adequate hydration or not. Also about the, yes, and also would like to know what type of the anesthesia was given to the patient, and would like to know about also inappropriately that how much blood loss was there, and was there any history of complication during surgery, and about also whether cesarean was difficult, any damage to the organ, especially urinary tract injury. After cesarean, post-operatively, I will review about the hydration status of the patient, whether the patient received adequate fluid or not, and she was monitored properly or not, and whether there was any hypotension or fever post-operatively. And also about the assessment for DVT done or not, patient was given, thromboprophylaxis or not, and would like to review her assessment chart to know about her input and output, especially that how much patient made, 24 hours urinary output, and will also know about the bowel bursts. And of course, I will, after taking this detailed history, then I will do the examination. And examination, it will be done with patient permission in presence of the chaperone. and I will assess overall general condition of the patient, and I will do the head-to-toe examination of the patient. I will check the hydration status of the patient and the dehydration sign. For this, I will check her eyes, tongue, and also skin. Excuse me. Right. In examination also, I will check about, I will do abdominal examination, and abdominal examination, I will do tummy examination, will see the wound dressing is whether dry or soft, any seepage, any oozing or discharge. Also will check if brain is there, then what is the output in the brain, and also will do the vaginal examination, in which I will check the any abnormal vaginal discharge or any bleeding period, and also I will do the leg examination. Will check the any swelling or any tenderness or redness. After examination, I will run some investigation. As already investigation have been done, but some investigation I need to repeat. Especially I will go for the urine test to rule out any infection, and also will go for the full blood count to check again her WBC count to rule out infection, and also she is anemic, hemoglobin level, and serum lactate level. It will help also regarding the sepsis, and her kidney function test, and some X-rays will be done also, like chest X-ray, and I will take also cultures like high vaginal swabs, and she's running fever, urine culture, and blood culture as well. Regarding further management, yes, I will also go for the ECG because her potassium level is raised. Regarding further management, as patient is running fever, I will, of course, involve a multidisciplinary team for her case, involving my consultant and also nephrologist and microbiologist and midwife, specialist nurse, and also as patient is having a, higher side potassium, so we need to correct it. Also, we need to give her IV hydration because she's in a sepsis, and we will maintain her IO chart, as well as we will strictly monitor her vitals, and also we will start her broad-spectrum antibiotics, and also we will assess her for BT, and accordingly we will decide for the thromboprophylaxis, and right.
Okay. Few seconds more if you want to add anything. And
Yeah.
clinical governance management.
Yeah. There will be the clinical governance part as well. We will document the all events, and also we will debrief the patient, family, and the team, and also we will perform the duty of candor, and we will write the incident report, and will on the risk management, and also once results will come, we will conduct the departmental meeting.
Yes.
And results will become, then we will disseminate to the others through the meeting. And also we'll keep the patient and follow up once patient will be stable. Right?
Time up. Yes. Okay.
I'm sorry.
Yes.
Yeah.
I know candidates, they will say everything, but in the end, they forget the clinical governance. So management part always, clinical management and the famous Ds. Never forget those Ds.
Yes. Well, Dr. Shabana just made our life very easy. Especially I will talk about myself. You know what? Especially root cause analysis, that station
Yes.
was quite difficult for me. But when I gone through your station, believe me, it was very easier for me to remember each and everything because you made
Thank
it
you.
step by.
Yes.
So I really for this thing. Most of your stations is quite easy for us to memorize it. Because so much information within a 10 minutes, that is a quite difficult task. This is a complete topic we are going to give, I mean,
Yes.
explain in a 10 minutes.
Yes,
So
because
then I
you
really
know,
appreciate
thank you.
illustrations are wonderful.
Thank you. Because in simulated patient tasks, what I observed that in the real exam, see, if you divide 1 minute will be your introduction and aim and agenda setting. Another 3 minutes, 3.5 minutes will be your history taking and examination. So 4.5 minutes gone. Okay, this is only you. Plus 1 minute, here the role player will give you a lot of informations in the history taking. So 5.5 minutes gone. Then when you will start discussing your management, for you it is only 4 minutes. Another 1 minute, the role player is talking. So for you people, it is only 8 minutes. It is not the complete 10 minutes. So how much will you speak? How much information you will give? Even structured discussion task, it happens like that. So
Yes.
thanks for your appreciation. Okay, my dear. It was difficult task when it came, but yes, again, you have to. In management is always your history, examination, investigation, management. History is your like same. It will be like simulated patient task, but never forget your clinical governance management part in these scenarios. Okay, let's start. Let's discuss the answer. Hello, I'm Maria and I'm ready for the discussion. So summarize the case. Remember this S bar. So the patient is post-cesarean section with anemia and fever, and she had a history of twin pregnancy. She went into labor and had to undergo emergency cesarean section, and she had severe bleeding. She also received blood transfusion. Now, on observations, the blood pressure is low and temperature is high. Investigation. So there is deranged kidney function test. Potassium and serum lactate is high. So in the examination, when you will get the chart, of course, you have to quickly see the last thing, last 48 hours, what's happening here. This is always important. So white cell count is very high, hemoglobin is low. So MCV is slightly low and platelet is normal. Just quickly have a glance. Urea is high, like creatinine is high, and then your lactate is also high. And potassium 6.1. This is also high. Okay. So management. So for the management, I have to take the detailed history from patient, offer examination, offer investigations, and then discuss the management plan. So keeping in mind differential diagnosis of a condition. So what could be the differential diagnosis? Her condition could be because of dehydration due to hypovolemia or fluid imbalance, bleeding, sepsis because temperature is high, lactate level is also high, nephrotoxic medications leading to acute kidney injury. Our patient is on gentamicin and ibuprofen. Where is it? Okay, not gentamicin. She's on ibuprofen, non-steroidal anti-inflammatory drugs. Then it can happen because of ureteric injury during the procedure. There can be kink in or blockage of the urinary catheter. Then coming to your history part. So history, you can, for your convenience, divide into pregnancy history. So I would like to know the details of her pregnancy and would like to go through her antenatal case notes, whether she was having regular follow-up, any history of anemia before, what was her hemoglobin, any history of renal condition before or history of UTI, and whether she was updated with the vaccines, or you can say here COVID vaccine. Anyway, we are not in the COVID era now. You can remove this as well. Then regarding the labor and delivery, how long she was in the labor, any history of spontaneous rupture of the membrane, what was the color of the amniotic fluid, whether it was meconium stained, any foul smelling discharge, whether she had repeated vaginal examinations. Then cesarean section, the details in the pre-op period, whether CS was delayed, there was prolonged pre-op starvation, and whether she was given adequate fluids or not. What was the type of anesthesia she received? Because with spinal, there is risk of hypotension, hypovolemia, and decreased urine output. Then intraoperative details. So whether CS was difficult and long, whether there was any complications, what was the estimated blood loss. And for that, I would also like to go through the operation notes, whether there was any urinary tract injury and whether it was repaired or not, and whether she received prophylactic antibiotics or not after ruling out allergy. Then I would like to know about the post-operative details, whether the patient was well hydrated, she received IV fluids, oral intake, fluid input-output chart was maintained, and what was the urine output. And patient's observation was maintained on the news chart, whether she had any nausea or vomiting, because it can also cause dehydration, whether she was able to eat and drink properly, whether she was walking and whether she was active, whether she had any symptoms of VTE like chest pain, leg pain, or swelling, and how about her bowel pulse. Then regarding the examination, I would like to examine her with the permission and in the presence of chaperone. It will be head-to-toe examination. I have to see whether the patient is conscious and well-oriented. How about her general condition? Any signs of dehydration? So I have to check her eyes, tongue, and skin turgor. And hemoglobin is low, so I have to look for signs of anemia like pallor, breast examination, check for breast engorgement, abnormal nipple discharge to rule out any postpartum sepsis, chest and heart. So I would like to assess the breath sounds and the heart sounds. Then abdominal examination will be done to check for any tenderness, abdominopelvic collection, any swelling, palpable bladder. I would like to examine the wound and the dressing to see if it is dry, whether there is any oozing or any discharge. And if there is any drain, then I have to assess the output and palpate the renal angles to see if there is any tenderness. Then vaginal examination, inspection to see if there is any bleeding, any discharge, estimated blood loss. And we'll take the high vaginal swab at the same time to rule out infection. Then leg examination to check for signs of DVT, if there is any leg pain, swelling, or redness. Then comes your investigations. So start with the simple ones, the urine dipstick, check for infection, white cell, red blood cell, glucose, protein, and nitrites. Okay, so which one is missing? We have to do that in the urine dipstick. Now, blood test, which are done. So here we can see if we have already commented on this, then no need to comment again. Urine, which is missing, we have to do that. Okay, so white cell count is already high, indicative of infection. Hemoglobin is low, indicative of iron deficiency anemia. CRP is high. Serum lactate is also high, indicative of sepsis. And potassium is also high. Kidney function test is deranged and estimated GFR is low. Now, we have to request for liver function test and arterial blood gas analysis. The cultures needed will be high vaginal swab and culture, urine, blood, and throat culture. Imaging needed will be X-ray chest for any locus of infection. Now, patient will need ECG because potassium is raised. Also, ultrasound scan. This will include the kidney scan, abdominopelvic scan to check for abdominopelvic collection or hematoma. If needed, CT abdomen and pelvis. Now, regarding the management, so sepsis care bundle should be started within the first 6 hours. Patient will need MDT management, including my consultant, anesthetist, nephrologist, urologist, microbiologist, drug specialist, specialist nurse, and the midwife. I will be explaining the diagnosis to women and her partner and relatives. So most likely this is sepsis and acute kidney injury. And we have to, I will go for correction of hyperkalemia because it will increase the risk of cardiac arrest. Ask the nurse to insert IV cannula. IV fluids are given for hydration. And maintenance fluid will be given once patient is euvolemic. We have to maintain the fluid input, fluid output chart, avoid fluid overload because it can cause pulmonary edema. If needed, central venous pressure monitoring has to be done. If there is no urinary catheter, then I will be asking my nurse to insert it to assess the urine output. Then I will be reviewing the medications, and if she's on nephrotoxic medication, like patient is having ibuprofen, it has to be stopped. And I will offer simple analgesics like paracetamol or opiates, but no non-steroidals. Continue broad spectrum antibiotics, and it has to be started within the first golden hour. She is having iron deficiency anemia, so she can be given hematinics orally or injections. VT risk assessment has to be done and offer thromboprophylaxis to reduce the risk of thrombosis, provide support for breastfeeding, follow the infection control protocol. Now, regarding the further management, patient has to be admitted in HTU. She will be under close monitoring and observation on the news chart. Daily review has to be done by the gynecologist and urologist. Daily urine dipstick has to be done. Daily serum urea, electrolyte, creatinine, and correct them accordingly. Nutritional assessment is important. We have to offer the patient iron-rich diet and avoid potassium-rich diet. We will discharge the patient when she is stable and tell her about the warning signs that if she has any abdominal pain, vaginal bleeding, fever, dysuria, difficulty in passing urine, she has to report to us immediately. Give her the contact numbers. Clinical governance point, it has got asterisks in patient safety. So if you will talk about everything in these post-op complication stations, and you will not talk about the clinical governance, your patient safety will compromise. It will become zero. So just remember the D's: documentation of events, debriefing the patient and relatives, debriefing the team, performing duty of condor, DATIX, that is incident reporting, and informing the risk management team, arranging departmental meeting, writing reflection in the e-portfolio, discharge summary has to be complete, and all the events has to be mentioned, and drills and skills if there is any other stations like PPH or something. So enough. This one is your even if you will say 5 Ds, you will pass this one. What about the follow-up? So follow-up will be by gynecologist and nephrologist, and also with the GP later on for 2 to 3 years, because there is risk of developing chronic kidney disease. So she will be having a long-term follow-up. So this is how I'm going to manage the case. Bye. Next, I already told the station, vaginal hysterectomy. Who is going to do it?
Mantu?
Anita's voice?
Yes, ma'am.
Yes.
Anita.
Do it, please.
Yeah.
Take you 2 minutes. Even if you know the station, just organize yourself, huh? Yes.
I'll start.
Yes, start, please.
Hello, I'm Anita. I'm going to the case scenario. I'm ready for the discussion.
All right. So I have 3 questions. First, you will explain the steps of vaginal hysterectomy. At the same time, you have to tell how are you going to minimize the risk and complications before, during, and after the procedure, and demonstrate and justify the correct use of instruments. So go on, please.
So this patient, she's a 52-year already with previous 2 cesarean sections. So considering this, and also I've been provided with her BMI. She's 42. It's 42, and she's a non-case of diabetes. So I have certain risk factors for her, like 2 cesarean, BMI 42, and also diabetes. Considering all these factors, her care will be. I'll involve my consultant. My consultant will be there during the surgery, and MDT care. Shared care will be done for her, like involving the diabetologists, dietitians, and also the diabetic nurse. And throughout the pre-op period, during the pre-op as well as during the operation, diabetic control has to be maintained, glycemic control has to be maintained, and also adequate hydration, hydration has to be checked, and stockings may be considered. I'll check for the informed consent of the patient. I'll also review whether her bloods for the full blood count has been sent, on proof and safe has been done for her. And also WHO checklist has been done for her, and also enhanced recovery will be followed, and also whether the pre-anesthetic review has been completed for her. After that, our patient will be taken for the operation. Patient will be placed in the lithotomy position, and antiseptic dressing and wrapping will be done. My first step will be to evacuate the urine with a metal catheter, and also the metal catheter will help me to see the lower limit of the bladder, extent of the bladder. Following this, after emptying the bladder, I'll do a bimanual examination to assess the mobility of the uterus, the size of the uterus, and also the adnexa. Following this, a speculum will be inserted in the posterior vaginal wall, and both the lips, anterior and the posterior lips of the cervix, will be holded with the Valsalm instrument. And it will be pulled. Traction will be applied downward, and after that, I will infiltrate and lidocaine with adrenaline solution in the subepithelial space. And before infiltrating, I will pull out the plunger of the needle to see whether I'm not infiltrating into the blood vessels, to avoid any complications. And also this will help me in dissection, in obtaining the space between the bladder and the vaginal and the between the bladder and the cervix. And also it will decrease the post-operative pain and bleeding. Following this, I'll place a circumferential incision at the lower extent of the vagina, around about 2 centimeters above the opening of the cervix. In this a circumferential incision will be placed with the help of the knife or either a diathermy instrument. After this, I will try to mobilize the bladder by separating the cervicovesical fossa, and the bladder will be pulled up. This will be done with the help of the scissors, Mayo scissors. But I have to be careful. The tip of the scissors has to be pointed towards the cervix, not towards the bladder. Once the bladder is pulled up, this will help me in removing the ureter out of my operative field. Also, now I'll go to the post POD, and I'll try to open the posterior pouch by applying two needle holders, and in between I'll open the POD with the help of the blunt scissors. And here also the tip of the cervix has to be the tips of the scissor has to be towards the cervix, and I'll also be careful there are no loops of bowel in between. Once the POD is opened, I'll try to identify the uterosacral ligaments by putting my fingers of the left hand, and under that guidance, I'll apply straight hysterectomy clamp at right angle, straight hysterectomy clamp, taking the tissue of uterosacral ligament and the cardinal ligament, and both and I'll also ask simultaneously, I'll ask my colleague to apply traction on the opposite side. And the uterosacral ligament, cardinal ligament will be clamped, cut, and ligated, and also transfixed. The two end of the sutures will be kept long for further support of the vault, and it will be at the moment it will be attached to the drap. After that, I'll insert my finger, and as the bladder has been pushed up and a retractor has been placed in, I'll try to put my fingers and make prominent the uterovesical pouch, and I'll apply 2 arteries, and I'll open the anterior pouch, and then the uterus will be taken out. After that, the next clamp will be the uterine artery. Uterine artery clamp will be applied. It will be lateral to the uterosacral ligament, and also I'll have to be careful. Both the anterior and the posterior reflection of the peritoneum has to be taken. and this clamp will be clamp cut and ligated, but it won't be transfixed as this is a vascular clamp. And after that, and similarly, the process will be completed on the other side. The third clamp will be involving the tubo-ovarian ligament. And before that, I can also I'll do the examination and assess whether there is any pathology in the adnexa, and if not, tubo-ovarian clamp will be applied. The clamp here we can, as there may be the clamp may be, the tissues may be quite broad, so we may apply 2 clamp here, and it will be clamp cut and ligated, and the sutures will be here also kept long. And in case we have to remove the ovaries, in that case, infundibulopelvic ligament will also be taken in the clamp. After that, the uterus will be delivered, and my next step will be to hold the vaginal vault, so to prevent future vault prolapse. So this will be done by taking the McCall stitches, where it will involve taking the uterosacral ligament on one side, the posterior peritoneum, and vaginal mucosa, and the uterosacral ligament on the other side, and the sutures will be at the end tied with the vaginal vault. And after this, I'll also check the hemostasis of the pedicles, and there is no if I'm assured with the bleeding, there is hemostasis is adequate and there is no bleeding, vaginal vault will be closed. It may be done either vertically or horizontally in continuous locking fashion using Vicryl polygalactic sutures, and in polygalactic sutures, yes. And after completion of the process, I will check whether the vaginal vault is descending to the introitus. If it is descending to the up to the introitus, if it is so, then sacrosupinous sutures may be taken to fix it again. And then after that, instrument count, swab count will be done, and hemostasis will be assured. Vaginal catheterization will be done, which will be kept for 24 hours. Vaginal packing will be done, which will again be kept for 24 hours. Patient will be observed in the post-op recovery ward for 2 hours, where the intake output will be monitored, vitals will be monitored over the news chart, and patient on the next post-op day, patient anesthetist and the consultant will come and debrief, will talk to the patient about, and the midwife will also discuss about the discharge plan of the patient. And once the patient is fit and fine, our vaginal pack will be removed after 24 hours. And also the catheter will be removed. And after removal of the catheter, post-void residual urine will be checked for her. And if she is voiding adequately, she may be discharged home. With some warning signs, like in case she has any bleeding, any foul smelling discharge, any pain, she has to report to us immediately, and we'll give her 24/7 contact numbers.
Right. Okay. Time is up, but just the last question. What are the complications of VH?
Immediate complication will be either I won't be able to deliver the uterus, or either there may be some injuries, there may be some bleeding. And in the late complications, there may be infection, pain, bleeding, again, late bleeding. Also, there may be difficulty in voiding dysfunctions may be there. And DVT.
Mm-hmm.
That
Long term, I mean, vault prolapse later on?
Yeah, vault prolapse, yes.
Yes, some voiding dysfunction and stress incontinence can also happen. Well done. So you have memorized all the steps. Very good. Instrument uses mainly Zeppelin. It is curved and straight.
And we need to name the instrument, or just
no. Many candidates said, and what even our preparation days, we were told that you just have to say the straight clamps and the curved clamps where it is used. That's all. Yes. Okay, so
Yeah, I have one question. Is it mandatory we are performing the vaginal hysterectomy, simultaneously we go for the mechalcolpoplasty. Because most of time, means it's not necessary. We go for the mechalcolpoplasty. Because here we are also mentioning. So we need to just tell them about the mechalcolpoplasty.
Because
we
you
have-
know, I took this from the talk on vaginal hysterectomy. There was a talk, it came in 2021 or 22. After that, vaginal hysterectomy came in the exam. And they have mentioned about the mechalcolpoplasty. That is
Okay.
why I have mentioned it here. I will share that talk on VH.
Okay.
So my answer is from the resources from the book as well as from the talk, both. The complication is there is a very nice box given in the talk. It is from there. Okay. All right. So there will be some comorbidity in the patient when they are asking about the hysterectomy, total abdominal hysterectomy, anything. It is not very straightforward that you will just tell the steps. It may come rarely, but usually you have to keep in mind how are you going to mention the comorbidity and how to reduce that risk because of the comorbidity. All right, so you are Anita. Hello, I am Anita and I'm ready for the discussion. So I have to discuss the steps of vaginal hysterectomy in this patient. My patient's BMI is 42. She's morbidly obese. So the consultant has to be there during the procedure because procedure can be technically difficult. Patient has diabetes. She should have good glycemic control preoperatively, intraoperatively, and postoperatively. Then MDT care is important, including diabetologist, dietitian, and diabetic nurse. Then prerequisites, I will make sure that patient has given the written informed consent, blood has been sent for full blood count and group and safe. Enhanced recovery program principles are followed in patients without any comorbidity. Followed a WHO safety surgical checklist. Patient has to be reviewed by anesthetist and it can be either like regional anesthesia or general. Preferably, it is regional anesthesia. Now, coming to the procedure itself, so the patient has to be placed in lithotomy position. I will be cleaning and draping the operating area. Then I will evacuate the bladder with the metal catheter to keep the bladder empty so as to reduce the risk of injury to the bladder. Now, metal catheter is used because it will also help to detect the lower limit of bladder wall in relation to the cervix, and then insert the Foley's catheter. After that, I will be doing the bimanual pelvic examination to assess the size and descent of the uterus and to exclude any pathology. Then I will insert the sim speculum, grasp both the lips of the cervix with 2 Valsalem with the help of my assistant. So when you are involving your assistant or even when you are involving your nurse, that is also communication with colleague. So after that, I will pull the cervix down to the level of the introitus. Then infiltrate the subepithelial tissue circumferentially at least 2 to 3 centimeters above the cervical os with lignocaine and adrenaline in saline. This will help to delineate the tissue planes and will decrease the perioperative bleeding. So this is you're holding the lips of the cervix and infiltrating the lignocaine. And then just one line that while injecting, I will withdraw the plunger to avoid any inadvertent injection in blood vessel to avoid trauma and toxicity. Then I will be giving circumferential incision around the cervix, either by knife or diathermy at the cervicovaginal junction, then reflect the vaginal skin upwards. So this will be your incision here. And if there is a cystocele or anterior prolapse also, then the incision may be modified to the inverted V or triangular shaped incision. After that, I will be identifying the cervicovesical ligament. This one, and divide it anteriorly, reflect the bladder of the cervix superiorly and hold with the Landon retractor. Now here you have to talk about because there can be risk of injury to the bladder and ureter, so the bladder has to be pushed upwards with a gloved finger or a gauze. Ureters are reflected upwards on each side to reduce the risk of injury to bladder and ureter. Now, if the patient has two cesarean sections, so we have to be very careful here. If there is any adhesion and any difficulty in dissection of bladder, then I have to involve my consultant. After that, we will reach the pouch of Douglas. So I will be lifting the cervix upwards to reach the pouch of Douglas peritoneum. So when you're talking about pouch of Douglas, remember there is risk of injury to the bowel. So this will be opened with blunt scissors, like Mayo scissors, or remember the blunt scissors, okay? Open it carefully to avoid any injury to the bowel. This will allow identification of the uterosacral and cardinal ligaments. So this is going to be your first pedicle here, because in vaginal hysterectomy, we know we are going from down to top. Uterosacral cardinal ligaments. After that, there will be your this one, uterine pedicle, then your round ligaments, ovarian ligaments, and all. In abdominal hysterectomy, it is from top to bottom. Your ovarian ligaments, the round ligaments, then comes your uterine artery pedicle, and the last one is going to be your uterosacral and cardinal ligaments. So now what you have to do here, you are going to insert one finger posteriorly behind the uterosacral and cardinal ligaments. Then identify these pedicles. I will ask my assistant to mobilize the uterus to one side, clamp them with the straight hysterectomy clamps away from the ureter. Then clamp, cut, and ligate with transfixing sutures to avoid slippage on one side with the help of my assistant. Involve your assistant. It is your communication with colleague. And repeat the same on the other side, may be done in 1 or 2 steps. So depending upon the size of the uterus and all, like if you're able to take both the ligaments together, well and good. If otherwise, you can clamp them separately. Here, I will be leaving the suture long and clip through drapes. Then, I will not be including too much tissue in the clamp because there is risk of slippage and it can cause post-operative problems. And I will not be pushing deep to avoid injuries. After that, I have to identify the uterovesical pouch by inserting index finger from behind the uterus and then open it. Now, again here, how are you going to open the uterovesical pouch? So the bladder has to be reflected up, and then I will pick the uterovesical pouch peritoneum with the tissue forceps, open it with my finger or hold with 2 small artery forceps, cut in between with a curved Mayo scissors. Now, the question asked in the exam was that where are you going to point, keep this Mayo scissors? How are you going to hold it? So I have to make sure that the curve is not pointing up. Otherwise, it will cause damage to the bladder, isn't it? To avoid harming the bladder base. Then I have to identify the uterine artery pedicles, and it lies just above the previous pedicle. That is just above your uterosacral and cardinal ligaments. Here I will be using the curved hysterectomy clamp. Some uses the G. William clamp also. So like my colleague who is working in NHS, they said everywhere they are using the Zeppelin only. To clamp, cut, and double ligate on one side and repeat the same on the other side with the help of my assistant. Here, stitch is not transfixed because it is a vascular pedicle. Here, I have to double ligate and double ligate because there is risk of bleeding because it is the uterine clamp to secure hemostasis. Take care not to damage the ureters. Cut the suture short. Clamps should include the anterior and posterior folds of the opened peritoneum to ensure all branches of uterine artery and veins are secured. Then deliver the fundus of the uterus through the vagina. After that, I will be identifying my third pedicle, that is the tubo-ovarian pedicles. This will include the round ligament, infundibulopelvic ligament, and broad ligament. So we will include the infundibulopelvic ligament if ovaries have to be removed. So if ovaries have to be removed, then we are going to keep the clamps lateral to the ovaries so that everything is going to be included. Then here, I will be using the curved clamp to clamp, cut, and ligate on one side. Repeat the same on the other side with the help of my assistant. Leave the suture long so that I will be able to identify the pedicles. Now, once completed on both sides, the uterus and cervix can be removed, and then I will be inspecting and palpating the ovaries if I have saved the ovaries. Okay. Then, yes, okay. Then hand over the specimen to the scrub nurse, ask her to label it correctly, send it to the lab for histopath examination. I will cut the redundant vaginal skin, but I will be avoiding removing large part to avoid vaginal shortening and dyspareunia. Then I will check the pedicles for hemostasis, close the vaginal wall with continuous locked or interrupted sutures using Vicryl or PTS. Now, reinforcing of the uterosacral ligament with the walled sutures. So this is what you were saying. All right, so this will include the posterior peritoneal edge and the lateral edges of the vaginal vault. So we know this will prevent the risk of vault prolapse and enterocele by obliterating the pouch of Douglas as high as possible. The broad ligament pedicle can also be tied together. What about the sacrospinous fixation? This is recommended when the wall descends or could be pulled to the introitus during the closure. So this is the VH steps, and there was this cystocele repair also in the exam, and please prepare that station. It is coming in the exam for the last 2 consecutive years. Very important station. Now, at the end of this procedure, I will ask my nurse. So involve your nurse and other communication with colleague. I ask the nurse to complete the counts and ask the assistant to check the urinary catheter tube and check for the color of urine in the urine bag. I will be inserting the indwelling catheter, urinary catheter for 24 hours, vaginal bag for 24 hours. Then post-op management, complete the operation notes, complete the documents. This will include all the steps of the operation. Ask the nurse to check the observations, check urine input, fluid input output chart, catheter care has to be explained to the patient, then analgesics has to be given. So this is also from the talk, this line that we have to avoid non-steroidals at least for 6 hours post-op to avoid increased risk of bleeding. You don't have to say all this in the exam. Analgesic will suffice. That's all. So after excluding the allergy. Thromboprophylaxis to reduce the risk of thrombosis, and patient will be followed up regularly in the ward until discharge. Upon discharge, talk about the warning signs, give the copy of discharge summary, patient information leaflet, contact numbers. What about the complication? Okay, this was talk 2022. Okay. So intraoperative damage to the internal organs, bowel, bladder, ureter, blood vessel, bleeding, and risk of blood transfusion, failure to deliver the uterus, and laparotomy. Then post-operative pain, infection, bleeding, vaginal vault hematoma, and risk of infection, vault prolapse, voiding dysfunction, stress urinary incontinence. Okay. Fine. Any questions?
Yes, I have one question. Can I,
Yes. Mm-hmm.
Dr. Shabana, there was another case scenario was included in today's task that was about broad ligament hematoma.
Mm-hmm.
After developed that, when I was reading that case scenario, just one question in mind, I just want to clear it.
Yes.
Patient had this complication, so of course we are going to write the incident report. Okay.
Yes.
So we are going to offer her also another surgery. So do we need to write 2 incident report or 1 incident report only? Because she had a
One
complication
incident report will be enough because you are the one who is managing this patient.
okay.
So
Okay.
broad
Even,
ligament hematoma, and she has to be taken for the surgery. So
sorry.
your question is very nice question. So
Yeah.
2 incident reports, I will confirm this. I will confirm. Maybe in the same incident report, you can mention that she had surgery and then she had broad ligament hematoma. And the second thing is that we are going to take her for the surgery again. Okay, I will ask my colleague how are they managing such cases.
But
Yes.
in the renal failure case, no, ma'am, it came in my exam like the ovarian mass with 62-year-old woman who
Yes.
was operated, and she was given the same like reading. And the exam keep on asking what will be your immediate action, like that he was not satisfied, like sepsis 6 bundle, everything I said, but what will be the immediate action you want to take this woman, like that he was asking.
One is we have to stop the nephrotoxic medications. She
That,
was on
yeah,
injection gentamicin also.
yes.
And for the admission in HTU, a clinical
Yes.
governance management, duty of candor. Did you say about the clinical governance management in that station?
Yes, ma'am, I said about the DATIX report and all, but that and all is not the immediate action only. He's not satisfied at all. Like, what will be the immediate action you want to take, like that he was asking.
Oh,
Then further on sepsis 6 bundle, that and all he didn't reject, but he was not happy with.
okay. So I think maybe it will be stopping these medications, no, which are nephrotoxic medications.
Like gentamicin.
Yes,
That will be the immediate action.
most likely. Yes.
Shifting to HDU and like that. HDU.
Yes, admission in HTU, stopping this and explaining
Like,
the condition, clinical governance, and initiating the incident report involving the risk management team.
okay.
We do it
Like
very fast. Yes.
you have to suspect like a ureteric obstruction.
Yes. Start with the simple ones. Could be dehydration.
Yes.
Thinking of the urinary catheter.
I think they would have expected that only. Yeah.
Simple.
Like simple things. Yeah.
Yes. And because of this nephrotoxic medication which she is taking.
Stop.
Yes. And then any intraoperative injury.
Okay.
Because this
Yes, ma'am.
scenario came in my exam, same which you're talking about. I have my audio on that.
Okay.
2 years TH and BSO, and big drug chart was given there, and gentamicin was there.
Okay.
This scenario came. It's a big ovarian cyst, isn't it?
Yes, ma'am. Yes, ma'am.
Treated for that ovarian tumor was there. Yes. Okay. Fine. All right. So,
Thank you, ma'am.
welcome. Next, we will have the gynae list and then the labor ward list. That's all. Two more sessions. Fine. Okay, I will end the meeting.